Hi, everybody. Thanks for having me. If you're unfamiliar with Mental Health America, we are a advocacy organization, one of the first, similar to the American Heart Association. Our orientation is towards protecting individuals who live with mental health conditions. And as a disability rights organization, certainly we have a long history of understanding what institutions and systems create inequity and lack of consumer choice as part of an issue that continues to be perpetuated today. As a person, I think I found MHA much by accident and life circumstances, like many do, and fall into mental health because my family struggles with mental health conditions, both diagnosed and undiagnosed, and personally also have lived with depression and complex PTSD as young as 11. Maybe was the first time I realized something was not quite right. So I'm really excited to share our research and our information that's really born out of trying to be the most consumer focused, as Dr. Neal said. Our work that I'll be focusing on today comes from our work in MHA screening. MHA has been fighting for ubiquitous mental health screens for as long as we can remember, back into the early 1900s, but we took this all online when the internet gave us the power to reach people's houses and their rooms very intimately at low cost. So back in 2014, our program was doing pretty well, collecting, 500,000 screens a year. This year, 2020, maybe because of COVID, we've had an explosion in the number of screens that people come to take because of coronavirus. And maybe also, I can't uncouple this from our own marketing or, going out and telling people like, hey, if you think you have a mental health problem, maybe come and take a screen, right? So since COVID, we've absolutely seen a huge drastic leap in terms of the numbers of screens. Some of this is not surprising. I can add a link for individuals who are just interested in taking a deeper dive. We started to release data analysis monthly so that people can look at trends and changes from a number of perspectives across demographics, and we're starting to explore geography. But a lot of our census is, a lot of our data is specific to the U.S. population. About 8 to 10% at any given time might be international. And this is the framework from a lot of the data that we'll be presenting today, just as a response to COVID and our understanding of what it means to be consumer focused and making tools that are responsive to communities, particularly communities of color. So, along with seeing a huge leap in the number of screens that have happened since COVID started, we were also particularly concerned with the percentages of increase in number of people who screen positive. I think we expected that depression and anxiety would be on the rise, but the leap that we saw also existed for the number of psychosis screens that we saw. So prior to COVID, past year, 2019, the rates of positive screens for psychosis, for example, hovered around 66% to 68%. And then through the time, we saw not just an increase in the number of people who took a screen, but then we also saw a rise in the percentages of individuals who were screening positive for these issues. We're constantly analyzing the data, as I said. In 2019, we also added a question about asking individuals, reflecting on the reasons why you came to take a screen today and what supports you need. What are the 3 main concerns that you have that are contributing to your mental health problem? I think there were a lot of assumptions that were discussed as part of our team about what was bothering individuals, whether it was politics or coronavirus, and said the only right way to do this is to actually go to individuals and look at what the data says. So it wasn't surprising that, as we asked this question during this time around April, we absolutely saw a rise in the number of individuals who've reported that coronavirus was a concern. So, an average, about a quarter of individuals report that coronavirus is a concern. But it's not surprising that overwhelmingly loneliness and isolation is a serious risk factor for poor outcomes and was exacerbated by the coronavirus when people had to remote work or stay at home and lockdown. And certainly for us, a concern was among families where there was high level of trauma or intergenerational trauma or even home life conflict. So the data absolutely indicates some of the changes and the nuances that we see related to this. And I don't have a slide here, but we did also break down these concerns by race, and I'm going to focus specifically on thinking about race equity because 2020 has brought important and necessary attention to what it means to create tools that are meaningful for communities and all communities in an inclusive manner. When we did analyze the data across the racial background, it wasn't surprising that Black communities discussed that financial problems were their biggest concern. Latinos were most concerned about coronavirus and getting sick. And then our American Indian population was also identified at high risk and noted that past trauma was a major driving force for their own anxiety and depression. And I will also say, too, I don't have a slide here as well, but one of the interesting trends that we've seen across time because of our data is looking at differences across racial groups. So overall, there are various buckets, and there are a couple populations that stand out at higher risk, and that historically has been our LGBTQ youth, our American Indian population, and people who identify as having multiple races as part of their identity. And I want to say this as part of this discussion because I'll be bringing some of this back as a discussion for today. So what I wanted to share with you is that outside of creating digital solutions for individuals, our screening program exists to understand and use data to think about what users might want, right, from a prevention and digital intervention standpoint. And Dr. Neal talked through all the varieties of types of treatments that people are exploring. As part of our screening to support, so what happens after somebody takes a screen, we're certainly experimenting with a variety of kinds of supports that people are interested in and trying to just use the platform to see what sticks when someone comes in. As a part of this work, and I'm going to just draw on a couple of examples of our work throughout the slides, interwoven in it is a necessary process that we're exploring to make sure that our solutions that we're creating are built towards equity and specifically anti-racism, which we've understand is an important framework to think about as we create tools for individuals. So what I kind of want to show you today is a result of months of deliberation on our team to think about what questions we needed to ask ourselves to make sure that we are creating tools that were responsive to all people and took an equity and anti-racism lens as part of our creation and our development. So the main 4 questions that we ask is, are the tools that we create inclusive and representative? Are they responsive to needs? Are we making sustainable and systemic change? And is there a situation where what we're creating is harming communities? So as I go through this, I'm going to drive down to examples that we're seeing in technology and digital technology and mental health. So when you're exploring whether or not what you're creating is inclusive and representative, we know that in our research, we want to make sure that individuals are included from the get-go. So coming from a disability community, sometimes the mental health community is asked to join an advisory board, but only as an afterthought, only as someone who says, after the research is done, can you read this and let us know if we missed some gaps? The better frame is to make sure that we're being inclusive from the get-go. So are you including your consumers, the individuals who are impacted at the beginning, the middle, and the end stages of your research? Are they part of that development? Do they help guide the development? Which is incredibly important for you to make sure that what you're creating is inclusive and representative of the people that you're actually trying to serve. I think it's important or interesting to think about intersectional approaches. So, we certainly know from technology that if you create face recognition and your sample size is coming from a predominantly white sample size, like this is why we struggle from other cultures to have the capacity for our phone to answer to our voice or recognize our faces, right? We have many numbers of examples of how technology is not responsive to alternative faces or biometrics. I think it's very interesting from a biometric standpoint because you heard in this lecture series about multimodal data, thinking about biometrics. We know that these may be better than the PHQ-9, for example, in terms of being sensitive to a variety or a diversity of people. But I'm still concerned. We have many examples where even in biometric data, I'm not sure that the sample sizes are inclusive and representative of a diverse community. And an interesting nuance is around trauma. So we see that people might take, maybe you think of your diversity as only around race, but are you also thinking about intersectional issues like trauma issues, for example, where maybe response rates are a little slower? And is that because of race? Are we defining that issue because of race, or is it because of something that may have happened that's an intersectional issue? I'm not sure that the mental health community is as good as we could be about thinking about intersectionality, but as much as we struggle with this, I worry even more that mainstream research thinks about this even less. So an example is if I think about preventative technology that's used, for example, in the workplace, to think about productivity or presenteeism, are those companies going to be as rigid in their understanding of intersectionality around mental health as they would be in general? And so just taking a moment to pause and think about this is an important frame. Another interesting challenge that came up was around how do you evaluate your data where data is missing? And this is a really important issue when you think about people who come from mixed race backgrounds. We know that when someone, for example, is asked about their race, there's always the box that says other. And individuals who come from mixed or multi-race backgrounds may not say that they are multi-race or two races. They may check other. They may be more likely to check other and not say that. And then our data is not then able to, we sometimes think of that other data and set it aside rather than thinking about what might this data be saying, especially if the data itself shows that your other population is performing more poorly. It's important to think about what that might mean then about why a person would check other, for example, as a race. Responsive development is once you create a tool, we ask ourselves, like, did we create something that actually works for people? Does it reach people where they're needed? Have I established a protocol for when I develop the tool? Is there a way for consumers to let me know whether or not this works for them? And when I evaluate that data, does it come from, who does it come from? And what does that mean about who is responding to me and who this product is working for or not working for? I have this chart up here about people who identify as Black, who say that they want immediate support through the phone. And this was a long-standing issue where when we think about serving Black communities, we often say that, you know, Black communities don't want services because there's stigma in the Black community, which when you use ambiguous terms like stigma, there's no way to identify what stigma means. Is it my fear of discrimination? Is it that the treatments aren't responsive to my needs? Do I have providers that look and think like me? Or am I in a situation where I might be traumatized again because of the relationship that I might be having in a therapeutic relationship where the individual on the other side doesn't quite understand my race or my culture or what's happening, right? These are things that we often think about from an equity and therapy issue. This data point was so interesting to us because when asked what people wanted, most people don't want immediate support. So finding a population that says, I want support right now, brings us to pause. And the fact that Black communities are overwhelmingly, more than any other race, ethnicity, culture, is saying they want immediate support tells me that falling back on stigma, that term, as a fallback for why we don't provide services to Black communities is a cop-out, you know? maybe we need to be more intentional to say, here is a group of individuals who are asking for support. Are we actually placing supports in those communities? And that is the more appropriate question around responsiveness. It's not, do those people want the treatment, yes or no? It's, how do they want those treatments, and what are the best treatments that we can create to meet the needs of individuals who are saying that they want them? We get this question a lot, which is like, because we know that our systems are not built towards equity, fairness, or kindness, we kind of question whether or not they will meet the needs of consumers, especially diverse consumers. And one of the questions we get is, well, what do you see that is being created that you feel is more responsive and is more a safer or better approach to creating equitable and positive delivery systems? And one of the answers that I often think is the project we're doing around crowdsourcing with UCI. It's that I do not trust systems to, like, when you think of business to consumer models or business to business models, B2B businesses, there are more inequity issues when you worry about a system forcing a product on a consumer and what happens to that situation, as compared to when a product is put into the hands of consumers themselves. So I, as a person, can choose to opt in and use and mold and shape this product the way that I see fit for my own recovery process, as opposed to one where I have to be in the healthcare system and swept into that product, into that type of treatment where I lose or have potential for loss of control or for negative consequences to happen. And I'll kind of share a couple of examples that we've seen that are particularly problematic in technology, for example. So crowdsourcing, right? We're going to collect as much information from a large number of people and help that data shape what works or doesn't work for other people, and have that be its own feedback loop where individuals themselves are collectively helping others. We have to ask whether or not the treatments that we're creating are sustainable and systemic. Part of that is asking yourself where the legacy or history of discrimination might occur. For example, our healthcare system. Is our healthcare system bent towards equity? Does it have, this is primarily an American-centric issue, where if you don't have a healthcare system that's universal, if you don't, who gets access to mental health care? Who gets access to the care that you're developing in terms of your digital technology? Is there a pay firewall? What does that cost mean that it's put onto the consumer? Are there groups of people that can afford it or not afford it? When I think of the data that we create, is there some material change that I'm creating that helps to reduce inequity issues? So when I think about democratized healthcare and technology, the fact that we can create something that's in the hands of users that's a lower cost item is a huge equity issue, because it helps to deconstruct that system. It does not require somebody to go into a brick and mortar. Being able to download it on a phone still has some equity issues, right? Somebody has to be able to afford a phone. But is a phone more affordable than what we know is the network of chaos that we've created in the healthcare system? And are we deconstructing and reconstructing? For example, if we know that the PHQ-9 is not responsive, how do we continue to evaluate this tool while reconstructing it to build other supports and other tools that might be better able? Which is why I really am I'm glad to see that we're moving towards multimodal data collection systems, that we're not trying to fit everyone into one small mold. We're thinking about global measures of how we understand mental health is a positive example of reconstruction. So yeah, our healthcare system fails people, especially in America. We need to think about democratized care. I'm excited that digital technology does offer that opportunity, right? People don't want a phone number, or they don't want traditional services, because we see how these systems continually fail our communities, and what they're looking for is maybe something that's a little more controllable in their hands, a little DIY. I'm not so ready to just jump right into therapy or hospital system I want to ease into this process. This is a research project that we're doing with Microsoft, Northwestern Toronto, and the University of Toronto. Honestly, it's just an example of democratized care. This is using text-based services to give people tools and education. Text is nice because people can have access to text-based technology in a low-tech phone as well as a high-tech phone. So thinking about the way that you use technology to reach people across the globe is a democratized and more equitable stance. And finally, just cannot emphasize enough that you need to think about the way that we're harming people in ways that you don't anticipate, right? So we had inklings, and people knew, especially Black communities knew that calling 911 was not an answer for them. And so you have technology that's created that, you know, it's like, do not call the police. This is not the option for certain communities that are impacted poorly by policing. But I don't know how much we as the mental health community took that to heart when we think about red flags when someone says that they think about death all the time, right? So in the past, we used to say as a red flag warning, hey, I hear that you're endorsing thoughts of suicide. Please call 911 or go to the nearest emergency room. This is not what we recommend anymore, and through a series of conversations with others who are doing this kind of crisis intervention work, our default now is to make sure that we're running those calls through the crisis text line, through the National Suicide Prevention Lifeline, through individuals who are better trained around a race equity lens to de-escalate and find the supports that a person might need that minimizes institutionalized care. Another example that we see is even in hospital systems. If someone goes to the hospital and is Black, we might not see those institutions as particularly dangerous. But if you look at the rates, for example, of how many people go to an ER where you're faced with an individual who is a security guard who has a gun, that Black individuals are more likely to go to the hospital or call 911 to get help from a mental health emergency and have catastrophic consequences. Death in the community, right? Or even when you go to the hospital, being charged with a crime post-hospitalization as compared to a crime. Charged with a crime or criminalization post-hospitalization is a huge factor, and also just forced hospitalization as even a scale of that risk factor that's an unwanted outcome. We want to decrease the number of involuntary hospitalizations and then understand that for some important communities that we may also be creating a pipeline to criminalization. And I will just end on the beautiful thing I think about this and what we need in 2020 is we often feel very much in despair, but this process has helped us to reclaim some hope because as a disability community, we understand what it feels like to lose control and lose hope over your future. And digital technology just orients us back to the things that make us feel power, to have empowerment, to have things in my hand, to self-determine, you know, the direction that I want to go and how I want to be at the driver's seat in terms of my own recovery process. And then more beautifully, technology offers us an opportunity to connect with community so that I know that I'm not alone and I get to do this simultaneously while using and engaging in technological tools that set me straight on my path of recovery. So it's a hope. It's a hope for positive change and innovation that is going to create a system that we all feel better about. And that's it. Here's my contact information if anybody has questions.